Hello, my name is Sarah Wright. I'm a physiotherapist from Queensland Children's Hospital in Brisbane, Australia. I'm joined by Joe Levitt, who's a
Hello.
colleague physiotherapist who works with the neuromuscular population in the hospital alongside myself. Between us, we have over 40 years' experience working with this exceptional cohort. Today, we're going to be looking at the complications associated with managing airway clearance in infants and children with neuromuscular disease, including neurodisability. First of all, we're going to talk through the factors to consider when it comes to the paediatric population. Well, obviously, age, that they're able to participate, obviously depends if they're a baby versus whether they're a teenager. And, you've got to consider that with how much they can participate in what you're doing.
Yeah. And I think that sort of even varies not just with age, but also cognitive function as well and ability to communicate, which varies.
Yes, obviously, communication can be key, and sometimes it's around the skills that you need, the non-technical skills we talk about communicating and engaging with any child in order to work with them, and make sure that they're part of the team regardless of their cognitive level. We also have to consider the impact of anatomical and physiological differences in infants and children. Now, we know in children they can get sick very quick. They usually get better quick, but it obviously can be quite a concern when they decompensate so quickly. And I also think it's important that when it comes to the ages and stages, effectively, that growth spurts can have an impact on their respiratory function. How often do we see a child who's suddenly grown and they come in with a chest infection?
Yeah, exactly. And I think too, as you're talking about, kids that being able to actively participate, they're part of the team. That's so important. That we also realise that some kids that may, look younger and we're thinking, oh, they don't really understand what we're talking about, but they're very smart. So a lot of our, say SMA children are so intelligent, and we really need to acknowledge that when we talk to them and get their opinions and their buying into their whole treatment program and what they're being involved with.
That's very true, and often it's key about knowing the child too in terms of the signs of respiratory decline, and they start to get weaker. They don't present, and we have present as a normal child would have, a child without this compromise with respiratory illness. Actually, they show no signs, isn't it? With the big worry is sometimes they usually go very quiet on you. They're sleeping more, and it can be difficult to sometimes pick up on those signs.
Yeah, and heart rate is often one of the first signs that they're running into trouble, where their heart rate skyrockets, and maybe their respiratory rate hasn't really changed a lot because of their muscle weakness, but their heart rate's really gone up.
I think it's key then also the family noticing the changes. We also talk about volume of voice, because they can't move necessarily as much. They usually they're quite active in how they speak or let you know. And if that volume drops off, then that's a sign that they actually aren't able to generate the volume to speak as loudly. So I think that's very, very, very clear. What word you've always said is lack of sign is an ominous sign.
Yes. So lack of voice, lack of sign is something that we find quite scary. Yeah.
The other key thing is their routine. So looking at what happens is kids often have a very clear routine in their day and how they're managing. So I think it's really important that we find out if those naps have got longer, if they're taking longer at the table, eating so much and feeding and everything else. It's often subtle signs like that can show.
Yes, like a baby not feeding as well. Like an older child, just they often fatigue more because they're having to use a lot of energy to chew and to eat, and they're fatiguing. And there's even some kids that may already be on non-invasive ventilation. They're asking to stay on it, and that's another big sign that you'll see that.
And we'll talk through that. That's exactly. Yeah. Now, clearly consent, is very important, and it's the family we have to consider. Physios do think what we do is not necessarily that nice, and it's very important that we engage everybody in the decision making of what we do and why we do it, and that clarity is very important. And consent from the child and the family to undertake that is critical. Mm-hmm. The partnership it starts from the very beginning.
There's also quite a number of risk factors for associated complications in this cohort of children. Immobility is a big one because we know that it's really important to keep these children as mobile as possible. Once they actually become immobile, they're off their feet, especially say the DMD kids, once they're not walking anymore, this really impacts their respiratory function. So as much mobility that we can maintain is really key. Whether, even if they're not able to walk, maybe they can do hydrotherapy and other things. So we know that's a big factor.
Most definitely, we know as soon as they become immobile, the risk
Yes.
to their respiratory function is, the evidence is there to say that. So we know that they become on our red flags, for us if their mobility comes compromised and they become, into a wheelchair for sure.
And I think another big one is that can result in some respiratory compromise is if a child's got bulbar dysfunction. So if they're not able to swallow effectively, and it's not just about swallowing their meals, their food, but their oral secretions, their saliva, and they can aspirate their saliva very easily, and then that can cause some respiratory compromise and respiratory illness.
And it's often silent, and we know that from a lot of the research we've done, particularly in the cerebral palsy population, that silent aspiration can occur and become an issue. So engaging speech pathologists is early, so they can review that and make sure that the child is safe, and really advise the family on the risk benefit. No one wants to stop a child from sitting enjoying a meal with the family. It's an integral part of family life, but it is actually important to know the risks, I suppose, and have those conversations.
Yeah, and I find really key to when you do meet with the family, just to and you're monitoring the respiratory function, just to ask those things like any coughing or choking episodes, whether it be at the table with fluids if they're drinking, any other times of the day they're noticing that, and in a baby, signs of gastroesophageal reflux. Getting onto those early, because especially that can cause a lot of inflammatory changes in the lungs and the airway.
And we're talking about that, and certainly it can be silent and it could cause a significant risk with that. And with reflux, obviously, we've often found positioning as an issue, particularly in the acute setting. So, for example, in an acute ward, they don't like to have a child can't possibly be lying down. They'll reflux, but actually we know with a lot of the neuromuscular children, their breathing is best either in their wheelchair, which is made to measure, or they lie flat, but relatively flat with their head slightly elevated, because that actually offloads the work of the muscles. So the education of our ward team around that, and listening to the child as to where they find the easiest for them to breathe, it's very important, because everyone really thinks that, oh my God, if they lie down they'll reflux. So I think it's getting that balance.
Yes, and especially those kids with the bulbar dysfunction that can't swallow and maintain their oral secretions very well, and clear them. When they come into the hospital and they're in respiratory distress, we're often thought for typically developing children in respiratory distress, we think, sit them upright. We've got to have them upright to breathe better. But in fact, these children will be pooling their airway secretions, and they'll actually have a gurgle or a purr in their upper airway, and they're at risk of aspirating. So the best position is side lying or even semi-prone to help with the drainage of secretions with gravity. Bed flat really works.
Exactly, well said. And certainly, that with the changing face of the medication and management now, that all the interventions with the longevity, bulbar dysfunction, we certainly think is slightly lagging behind in terms of as an issue. So I think it's become more apparent now, as is chest wall deformity. So in terms of the change in the chest wall shape and scoliosis, the significant risk factor to them in terms of their breathing and also positioning and pain and everything else. So we have to take that into consideration with any of our children.
Oh, definitely. Before, when we had some chest wall deformity due to poor mechanics of breathing, that's actually improved with the use of non-invasive ventilation, so chest wall shape. But now that the kids are up more against gravity, it's actually causing that chest wall shape change, so that we're seeing more of the scoliosis occurring. And so that's really important to think about that and how that impacts respiratory function.
And we know that we used to, 20 years ago, spinal surgery to try and correct that. We thought, hey, that might help their breathing, but we know that isn't the case. So the consideration for spinal surgery is now around pain management and being able to seating, etc., rather than function,
as opposed to lung function, just everyday function.
Yeah. And alongside the chest wall deformity, we now have osteopenia, osteoporosis, which is obviously more of an issue as they get older, but it's still significant in terms of bone density, etc. Now, another good reason to keep mobility ahead, but if we lose that, then there is a risk factor with that.
Yeah, and definitely mobility will try and maintain some of that bony integrity, but also now the use of steroids for the Duchenne muscular muscular dystrophy cohort has been great in keeping them mobile, but there's that sort of that balance between that and the changes it has within their bone mineralization. So really being careful about that. And so if a child does have quite a lot of osteoporosis or osteopenia, considering that with our airway clearance techniques, avoiding maybe some of our manual assisted cough techniques and using other techniques that we can use, or even some of our manual techniques that can cause pain or discomfort or may put the child at risk of fractures, rib fractures or so forth.
Got to be very careful of that.
I think also, we have some children now, of course, with the non-invasive ventilation, which is wonderful. It's in some ways reducing the frequency of respiratory illness because it's maintaining the respiratory function a lot better. It's improving their quality of life so that they can actually, enjoy activities of daily living. But also we need to remember that we can use it as a physio tool. And we can also use it to rest them. If they, sometimes these kids, they're doing a lot of function, and with a lot of the different therapies now, they're doing a lot more neurodevelopmental play, especially the little ones, but balancing that with their fatigue. And do we need to do some of these developmental activities and functional activities with the support of ventilation?
Yeah, and I think this is a challenge we also have if they become acutely unwell. If they're on the NIV, it's a lot easier than the mask ventilation. It's actually regionally, and when our children get admitted to hospitals, at least they've got that. We can support our colleagues to use that as part of physio. But if they're not on it and they become sick and the physios are struggling with because they're tired and they're not tolerating physio, how do you escalate that? We really struggle with helping to support our colleagues to make sure that they say, look, this child physio can do harm, and if they're going to tire with the techniques that we do, we have to make sure that we can advocate and say, hey, I think this child needs some form of support in order to be effective in our clearance, and that's something a role we have to play and advocate for, and that's often why we have those plans for the children, which we'll talk about, that's on there so that we can, the team can say, hey, this is where they're at this point, we need to add this.
Definitely, it aids advocacy for the therapists in the community or in the regional centre to be able to say, this child requires more support. Yeah, definitely. I think it's really interesting too because, often we think about when we use non-invasive ventilation, we're really thinking that it's the IPAP component. It's, giving that positive pressure to help support the ventilation, to keep the airway open. And we often, tend to be more conservative on the expiratory positive airway pressure because we don't want the child to have to work against that pressure on expiration because they don't have the muscle strength to be able to push against that. But there is a small number of children that really need that EPAP, don't they?
Yeah. Definitely. I think, certainly now that we're finding, and there's certainly some of the younger children with obstructive airways, or they may have some malacia, and therefore you're really trying to balance it out, aren't you, in terms of whether how much support they need and titrating that appropriately. But the good thing is the kids tell you, it's pretty obvious as you ramp things up and down. You've just got to look at them and they let you know very, very quickly as whether which one's helping, which one's not.
And I think with these kids, one of the big things is when you've got something right, because they'll accept what you're giving them. They'll be like, you can just see them relax into it. And you can see how it really just improves them.
So other things we need to consider, obviously it's a brand new world, and in the last few decades we've seen significant changes in this population, one in particular being the development of lung disease such as bronchiectasis. So through the wonderful medications and new therapies, through non-invasive ventilation, the longevity means that we are now getting more peripheral issues when it comes to secretions. And just because they potentially are doing more, doesn't mean they actually are moving enough to be able to move secretions as a child who would normally be running around, and therefore they can develop lung pathology.
Yes, and their cough isn't necessarily stronger either to help just, clear them on an ongoing basis. Yes. So definitely, and with some of the aspiration that we're seeing, whether it be silent or not, that is also causing damage to the lungs.
So we have to consider then with children with a diagnosis such as bronchiectasis, which would be found through a CT scan, but sometimes these children can show signs of it regardless, and you have to get that into consideration. You have to decide if they need daily physiotherapy. Now, we never used to do that. When the child was sick, we do physio. When they're well, they didn't need that. But we have to now consider and discuss with the family if we need to do some sort of prophylaxis in order to maintain secretion clearance. Yeah. So, that's a tough ask, and you're looking at, wellness versus exacerbation. That's where we now have our plans in place to look at this is what you do when you're well, this is what you do when you become unwell, and that sometimes means daily clearance.
Yes. Yeah, and I think, we know that in a paediatric setting that bronchiectasis can often be reversed if it's caught early enough, and if the airway clearance techniques that are used are used on an ongoing basis while those symptoms are there. So I think it's really important that we just sort of let the parents know and the family caregivers know that this is really important, that they can make a difference if they do continue this. And sometimes it may be something that resolves, but sometimes it may be something that just is ongoing.
Yeah. Obviously, thick secretions and mucus plugging, that's probably, that's one of our biggest challenges, but also one of the things when we can work out a solution, and then it's really important for us. That's what we're there for, I suppose, in terms of escalating management. There's the classic discussion around humidification and nebulization. We often have that challenge, do we add the humidification? Do we add nebulizers? What nebulizers do we add?
And I think it really is very individual. I mean, if a child has thick secretions and they're on, a lot of ventilation that's very drying, some form of humidification is important, especially if it's for a number of days, or if it's continuous. If we're just using some ventilation for physiotherapy, that humidification probably isn't quite as important. But if it's something that they're needing that support as well as with physio, I think some form of humidification is important. But yet, I think when we do think about nebulizers, that's probably another issue again.
Hypertonic saline. Again, it's about the risk benefits. Hypertonic can cause irritability, it can cause oversecretion, but it might also be very helpful in that particular patient. So I think it really is it's all about assessing, real-time assessment when you use any of those interventions.
Yes. And then maybe, once we find what works for one child, having that in their action plan so that we know, when this child is plugging, got lots of mucus plugging and secretions, they actually respond really well to 3% hypertonic saline, or this child, it just overwhelms them. They get too many secretions and they just can't cope, and it actually makes it worse.
Knowledge of the child is key, and the parents will often remember it too, so always ask them, have we used this before? Oxygen therapy, this is the thing, who needs oxygen? The rule of thumb was always oxygen is used for symptom management. It shouldn't be used for anything else. For children needing oxygen, there's a reason. There'll be something that you need to reverse. However, that's now changed again. Similar to what we talked about the upper airway, we're now finding sometimes in the young children that they do have sleep disorder breathing potentially and requires low levels of oxygen overnight. So it is about managing that, I think, isn't it, in the oxygen?
Yeah, definitely. Some children will go home on a very small percentage of oxygen.
And they often get weaned.
Yes,
and literally, as a child, as any child would be, as they outgrow the particular obstruction.
Yeah.
And bringing on to that ventilatory support, we're certainly introducing that sooner, I think, now.
Yes, now with a lot of the new therapies, as part of sort of the investigations, the research that's being done with those new therapies and looking at their impact on the respiratory system, a lot of the kids are actually having sleep studies earlier rather than waiting for some of the symptoms or the history to denote, we need to do a sleep study to see how this child's going. They're done a bit more routinely as part of the research. And so what we're finding that sometimes children do have sleep disordered breathing when there's no overt symptoms to sort of tell us that they do. And they're doing really well with that early NIV.
And the good thing for us is it actually adds another tool to our box for airway clearance if they need it for escalation. So again, it's so much simpler if they've got that device, they've got an interface that they're used to using, and then you can ramp things up rather than adding something new in. So I think actually from our perspective, it actually has been beneficial in that sense. And we've had several children that have come off, they've got better, and they actually haven't needed it, which again is investors with the head, but it's brilliant news in that sense.
Yes, and then we already talked how that NIV in the young cohort is really important in the way it's helped with the chest wall shape. Years ago, we'd have these children, from all their work of breathing, they'd have quite deformed chests, but now they've got beautiful chest wall shapes.
Yes, exactly. It's great, isn't it? And that impacts on then how we can handle and help assist. So it has multiple benefits in that sense. But obviously, it's still a burden to the family, so we have to consider that at every time. Talking about fatigue, well, obviously, we talked earlier about the signs of them fatiguing and being very careful of that. And often they may be saying they're fine, but they've not actually haven't moved or done anything necessarily. Then we come along and tell them very quickly. So it's really important to look for those signs.
Mm-hmm. And when a child is quite vulnerable, when they're acutely unwell, just having all those support around you if you need it. So if they have NIV, have it there and use it, because it's going to support them and prevent that fatigue. If not, having the bag valve mask, other things there, because if a child, as we talked about before, they can deteriorate very rapidly, and fatigue is just going to tip them over the edge. So really being conscious of that.
Yeah. And obviously, shorten the treatment sessions sometimes. So, we actually have to sort of short treatments more frequently to support them. And, sometimes it's about accepting that they're stable and they're settled. I might still feel there's some secretions there, but it's okay. They're safe, and let them rest and then come back, another time to manage that. I think that's very important.
Yeah. And sometimes, also, although we might use NIV as our getting air behind the secretions as part of our airway clearance, sometimes then leaving it on for a rest, to give the child a rest to recover from physio afterwards. So we can use it to recruit and recover.
You also have to consider cognitive status. So we work with these children. Some of them are exceptionally bright, and their vocalization and intelligence is how they best articulate their needs, and others haven't necessarily got the ability to communicate in that way, such as cerebral palsy or Rett. And then it's really important that we manage that and communicate with them whatever way that the family will can help us with in terms of managing and respecting their child. We've also got to consider the developmental delay. So we've talked already about chest wall dynamics and everything else, but positioning can really impact with someone with altered tone, like with cerebral palsy. Again, asking the family what position works best for them to breathe more comfortably can actually be the weirdest position, but actually the most relevant for them.
Yes, definitely. And also, we recognise that the family are have the best knowledge of their children. Like, they're the experts in their child's care in many ways, and they can report to us certain things that are really key, such as this shows it might just be like a blink of the eyes or a twitch of the face that shows the child's in pain, or the child is starting to fatigue, or something's happening, and we may not recognise those cues. So we really need to ask the parents, tell us what the signs are, tell us what works best for your child, because they know their child and they see them 24/7.
Yes, which really leads us to our final few messages.
Yeah, so we really want to keep it simple. The more complex an airway clearance therapy is, especially a home program, the more difficult it is, and it's a burden of care, but also, people will forget how to do it, and it won't actually happen effectively. Families are the experts in their child's care, and we work as a partnership. So we are there to provide expertise, we're there to provide support, to troubleshoot, to help them to figure out a good program for their child, but we really work together, and their input is so important.
And certainly with the progression of disease, which will occur, it's about supporting them through those stages, because it can be very, very hard to be facing some of the challenges that come along. It's our job to make sure we support them in that, and they feel they are supported. Yeah,
definitely. And then having a plan A and a plan B. So generally we're going to have, a wellness plan, and then a plan that escalates care. So that if a child starts to become unwell, there's a plan that they can work on at home. So we have action plans for our kids. So what they're like when they're well, when they're baseline, and some, as we said, for some kids with bronchiectasis, that will actually involve some airway clearance, that they're at baseline. But then for other kids, they're totally well, no secretions. and then they'll be escalating care. And some things they can do at home, but then there's a point where they really need to come to hospital and to present at the emergency room. And so that provides families with some guidelines of how to escalate that care and when to come. But we always say, if in doubt, come. We'll never turn you back. It's better to be safe than sorry, but definitely it's nice to have those guidelines, and parents really appreciate that.
And also they have the flags in the notes, so they know to call certain team members, so they don't sit around and wait. These children are too special to be sitting around in an ED, so it is important that they actually it gets escalated. They've come for a reason.
Yeah, and sometimes too in that sort of that what we call our sort of yellow zone, or amber zone, where the child's a bit unwell, but the parents don't think they need to present yet. There's that opportunity for them to give us a call to be able to maybe do a telehealth into the home, that we can view the child and we can reassure families, because sometimes it's reassurance that really goes a long way, and just saying, nope, you're doing all the right things, they're looking good, continue, carry on.
And I think the final message, I suppose, don't underestimate these kids. They're exceptional. We're very privileged to have worked with this population and their families for many years, and have seen a change across the world in their management. And it's very exciting times, but we still recognise that we need to be there for them, support them through challenging diagnoses, and the path towards adulthood, hopefully. So we hope this has been useful. Thank you very much. And goodbye.
Thank you.